So, in the non-insulin antidiabetic drugs, we have these nine classes of drugs that are used for the treatment of diabetes and type 2 diabetes mellitus. And in these, we have insulin secretagogues, which is the first class. It is subdivided into two further classes, sulfonylureas and meglitinides. And as the name indicates, these are the drugs that increases the secretion of insulin from the pancreas. The second one is thiazolidinediones. We have DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 analog, alpha glucosidase inhibitors, bile acid sequestrants, bromocriptine, and the first line drug metformin, which comes under the class bigvanid. So these are the classes that are used to treat diabetes mellitus 2, and we will discuss them separately. The first line drug is always the metformin in the type 2 diabetes mellitus, and if a metformin monotherapy fails to allow the patient to attain or maintain glycemic control, we add other agents. Also, the choice of other agents, it depends on the comorbidities. For example, if the patient has a comorbid of cardiovascular disease, we will give them SGLT2 inhibitors or DPP-4 inhibitors, because these drugs, they also have a benefit in the cardiovascular diseases. So if the patient has a chronic kidney disease, we will give them SGLT2 inhibitors, because these drugs, they also have a beneficial effect in the kidney disease. So the choice of anti-diabetic drug, it depends on the comorbidities and the patient glycemic control as well. So now we'll discuss these classes separately. Let's start with the insulin secretagogues. The first class is sulfonylureas, which is an insulin secretagogue, which means that it will increase the secretion of insulin from the pancreas. So we have two generations among this. We have the first generation drugs, which are called as chlorpropamide and tolbutamide, but these drugs are not used nowadays because of a great adverse effect profile, and they're not very effective as well. And the second generation drugs, which are glyburide, glipizide, and glimepiride, these are the drugs that are most commonly used nowadays. So we'll discuss the mechanism of action of these drugs. They increases the concentration or secretion of the insulin from the pancreas. So this is a cell in the pancreas, and we can see that the sulfonylureas, they bind with these receptors, and they will cause the depolarization of the cell membrane. This depolarization will increase the concentration of calcium. We can see that here the concentration of calcium is increased inside the cell, and this increased concentration will cause the increased release of the insulin. So this is how they have their effect, that they will bind to the pancreatic beta cell and they will lead to membrane depolarization. And after the depolarization, the concentration of calcium goes up, and which causes an increase in the insulin secretion. So this is how they act as an antidiabetic drug. The most common among these are used are glyburide, glipizide, and glimepiride. And the doses of these drugs are glyburide. It is available in a micronized and a non-micronized formulation. So for the non-micronized formulations, we give glyburide 2.5 to 5 mg per day or twice daily. The glipizide is 5 mg once daily or twice daily, and glimepiride is given in 1 to 2 mg once daily. So this is how these drugs are dosed. Now, the most common adverse effect of sulfonylureas is hypoglycemia. So if the patient has hypoglycemia, they will have all these symptoms, that they will be sweating, the patient may become pale, there is an increased hunger, fatigue, irritability or anxiety, rapid heart rate, or lack of concentration. So all these symptoms, they will occur in a patient with hypoglycemia, and it is a very common side effect with the usage of sulfonylureas. So any patient who remains unaware to the symptoms of hypoglycemia, you cannot give them sulfonylureas, because it is very common side effect. The less common side effects are usually rash, headache, nausea, vomiting. So these are the adverse effects that are less common, and there is a rare side effect with associated with the sulfonylureas, which is lactic acidosis. And how the lactic acidosis develop is that there is an inhibition of gluconeogenesis, which means that the sulfonylureas, they prevent the production of glucose. So in return, there is more accumulation of lactic acid. So this is how it causes lactic acidosis in the patients who are taking sulfonylureas. And the contraindications to sulfonylureas is that any hyper, because these are sulfa drugs, so any patient who are allergic to sulfur drugs, these drug called sulfonylureas, they are contraindicated. So any patients who have hypoglycemic unawareness, you would not give them sulfonylureas because they will remain unaware of any hypoglycemic effect. So any patient who have poor renal functions, we cannot give them glimepiride or glyburide, but glipizide is a better option in these patients because it is not excreted by the renal route. So we can give glipizide very safely in these patients who have renal functions. So these were the side effects and contraindications of the sulfonylureas. Let's move on towards the other drug. So meglinidides, they have the mechanism of action similar to that of sulfonylureas, which means that they will also increase the secretion of insulin in the pancreas. So they will increase the concentration or secretion of insulin from the pancreas, and they have a more rapid onset and shorter duration of activity as compared to the sulfonylureas. So we have two drugs in this class. We have repaglinide and neteglinide. So these are the two drugs that are in this class. And repaglinide, it is given in the dose of 0.5 to 1 mg before meals, and neteglinide, it is given as 120 mg before meals. So these are the doses in which they are given. They have the same mechanism as we have studied in the sulfonylureas, and the adverse effect of meglinidides and neglinidide is that they can cause hypoglycemia as well, just like the sulfonylureas. So they can cause hypoglycemia. They can also cause weight gain and upper respiratory tract infection. So the weight gain is associated with an increased secretion of insulin. More insulin than there, that means that more glucose will be converted into fat, and a weight gain can be reported. So upper respiratory tract infections are very common with meglinidides, with the uses of meglinidides. So we have to be careful while prescribing meglinidide in any patient. Now, the third class is thiazolidinediones. In this class, we have two drugs, pioglitazone and rosiglitazone. And the mechanism of action of thiazolidinediones is a little bit different from what we have studied in the insulin secretagogues. What it does is that they are going to, they are an agonist of an PPAR. So this is a peroxisome proliferator activated receptor. So this is the receptor which is activated by peroxisome proliferator. And what this receptor does is that whenever this receptor is um, stimulated, it will increase the expression of genes. And these genes, they are responsible for the metabolism of the glucose. So this is how they modulate the glucose concentrations in the body. So what it will does that these zolidinediones, they will act as an agonist at this receptor, which is peroxisome proliferator activated receptor, and it will cause the expression of genes that will result in the metabolism of the glucose, and this is how it will result in the improved insulin sensitivity. So we have two drugs. We have pioglitazone, which is given in the dose of 15 mg, and rosiglitazone, it is less commonly used. So this is a structure in which, so you can see that this is the receptor which is present in the cell membrane. Thiazolidinediones, they will interact with this receptor, and as a result there will be production of the proteins, and these proteins, they will increase the sensitivity of the insulin. So they have a very they have a mechanism of action that acts at the level of the genes. Now, they have some adverse effects as well. These drugs, they are responsible for the weight gain, and the weight gain, it is also associated because the metabolism of glucose will result in the formation of fat. It will result in the formation of fat in the adipose tissues. So weight gain is quite common in the patients who are using thiazolidinediones. Another very important factor or adverse effect of thiazolidinediones is the fluid retention. They are responsible for the retention of the fluids in the whole body and as well as in the retina, which is called as macular edema. So they are responsible for the retention of the fluid in the body. They're also the patients who are taking thiazolidinediones, they are at risk of potential bone fractures, and the reason is direct extension of its therapeutic or its mechanism of action. And what actually happens is that the ppar, the it is also, it's not only present, it's present in all parts of the body. It is also present in the bones, and as a result it will cause osteoblastogenesis. It will result in the bone remodeling, and in the process of bone remodeling, there is an increased risk of bone fractures. So, these drugs are associated with an increased risk of bone fractures as well. Also, there is a possible risk of bladder cancer because these genes, they are also present in the bladder, and they will increase or they will cause a proliferation of the cells, and which can result into bladder cancer as well. They also have a black box warning of the heart failure. Because they are responsible for the retention of the fluid in the body, they can precipitate heart failure in any patient who have diabetes mellitus as well. So, if the patient has documented heart failure, class 3, class 4, you would not give them thiazolidinediones. In fact, these drugs are contraindicated in the setting of heart failure, and if the patient already has fluid retention. So, these are the adverse effects that must be considered before prescribing the thiazolidine diones. Let's move towards the next class, which is DPP-4 inhibitors. They also have a very interesting mechanism of action. What they does is that whenever we take a meal, so there is peptide release which is called as GLP-1, and this GLP-1 peptide, it is increased during whenever we take a meal, and this GLP-1 then acts on the pancreas and causes a increase in the release of the insulin. So what these DPP-4 inhibitors does, that they inhibit the breakdown of the GLP-1. It means that the concentration of the GLP-1 will be increased in the body, and there will be an increased secretion of the insulin from the body. It also limits the or inhibits the glucagon release. So it has two mechanisms. We can see the first is that it increases the insulin release, and the second that it inhibits the glucagon release. And both these mechanisms, they result in the lowering of the blood glucose. So this is how they has their anti-diabetic effect. So the drugs in the DPP-4 inhibitors are sitagliptin, sexagliptin, linagliptin, and alogliptin. We give sitagliptin in a dose of 100 mg once daily. Sexagliptin is given as 5 mg once daily. Linagliptin is also given as 5 mg once daily, and alogliptin is given as 25 mg once daily. So the doses of all these drugs, they are adjusted in the setting of reduced creatinine clearance. So now they have a good anti-diabetic effect, and along with that they also have some adverse effects which are due to their physiological effects that they're acting in the body. So the adverse effects of these drugs Usually, the patients who are taking DPP-4 inhibitors, they have a slight modulation of immune systems, which results in mild reactions or mild infections, which includes upper respiratory tract infections and urinary tract infections, because they slightly modify the immune system in the body. They also, the patients who are having DPP-4 inhibitors, they can experience hypoglycemia symptoms that we have already discussed. So we must keep this in mind as well. They also have post-marketing reports of acute pancreatitis with the use of DPP-4 inhibitors, and the action or the effect is due to because they act on the pancreas to increase the secretion of insulin. So what they do is that they will cause a hyperplasia, they will cause ductal hyperplasia in pancreas, which can result in pancreatitis. So the safety studies of sexagliptin, to a lesser extent alogliptin, they have also shown an increased risk of heart failure in patients who are taking. So the FDA, they recommended warnings to package labeling of all DPP-4 inhibitors. So the contraindications, if the person has any previous hypersensitivity to these drugs, you would not give them. And also, if the patient has a history of pancreatitis, you would not give them DPP-4 inhibitors because they are contraindicated in that setting. Now we will move towards the SGLT2 inhibitors. SGLT2 inhibitors, they also have a beneficial effect in the setting of heart failure and chronic kidney disease. The drugs that are included in this class are, so the SGLT2 inhibitors, the drugs in this class are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. The mechanism of action occurs in the proximal convoluted tubule of the nephron. So here we have a structure of a nephron. From nephron, we have taken the proximal convoluted tubule here. And what they does is that they block or they inhibit the sodium glucose transporter. And as a result, more glucose is excreted out of the body. So it increases the glucose excretion. And this is how it has its anti-diabetic effect. It will block the SGLT2 receptors and increase the glucose excretion in the urine. And it also has some effect on gastric, delaying the gastric absorption. So we have four drugs in this class. Canagliflozin, it is given as 100 mg once daily and before the first meal of the day. It can be increased up to 300 mg. Dapagliflozin, it is given in the dose of 5 milligrams once daily in the morning with or without food, and it can be increased up to 10 mg. Empagliflozin is given as 10 mg once daily in the morning, and it can be increased up to 25 mg. And ertugliflozin, it is also given in the dose of 5 mg once daily. So these are the doses in which these drugs are given. Let's move towards the adverse effects. So as we have studied that they will increase the excretion of glucose, so there will be an increased urination. This is the first side effect, and we can understand by um, the mechanism of action. It also increases the rate of urinary tract infections. So there will be an increased number of UTIs. There will be an increased number of mycotic in, mycotic infections, which means that they can cause genital mycotic infections as well. As they excrete the glucose from the body, they also excrete water from the body, which can result in hypovolemic hypotension. They can also increase hypoglycemia if the patients are using concomitant other anti-hyperglycemic drugs and or insulin. This class of drug is also associated with some rare case of euglycemic DKA. DKA is diabetic ketoacidosis, which is a complication of diabetes mellitus. So this is also associated with the euglycemic TKA. It also increases the risk of bone fractures and decreased bone mineral density and foot or leg amputation is possible with canagliflozin. So any contraindication, if the patient has significant renal impairment, these drugs are contraindicated in them. And also it is suggested to ensure a euvolemic status in patient because it has a diuretic effect. It will cause an increased release of excretion of the water from the body, so it can result in hypoglycemic. So we must ensure that the patient is euvolemic before starting the SGLT2 inhibitors. And the next class is GLP-1 agonist. So these GLP-1 agonists, they are the synthetic analog of the human GLP-1. So GLP-1, what it does, that it binds to the GLP-1 receptors, and it results in the glucose dependent insulin secretion and reduction in the glucagon secretion, as we have already discussed in the DPP-4 inhibitors, because they have a same mechanism of action. The drugs in this class are exenatide, liraglutide, lixisenatide, dulaglutide, and semaglutide, and all these are the formulations that are available in the pen form, and they can be administered subcut. Exenatide is usually given in a twice daily formulation, and it is administered as 5 mics BD subcutaneously. Liraglutide is usually given once daily in the dose of zero point 0.6 mcg. Lixisenatide is given in the dose of 10 microgram once daily for 14 days, and then the maintenance dose is usually 20 mics once daily. Dulaglutide is given as 0.75 microgram subcutaneously once weekly. So this is a once weekly formulation, and it can be given in the once weekly. So this is a very important or interesting fact that is related to the dulaglutide. Then we have semaglutide, and it is also given as once weekly formulation. So you give them 0.25 mg, and it is administered once weekly, and dose titration once weekly at monthly intervals for additional glycemic control is also given. The oral formulation of semaglutide is also available, and it is given in the dose of 3 mg once daily. So the most common adverse effects associated with the use of GLP-1 analogs are GIT effects, which include nausea, vomiting, and diarrhea. And these are the GI effects that can happen if the patient is taking GLP-1 analogs. Hypoglycemia is very common, as it will increase the secretion of insulin. So hypoglycemia is common. So we must take this factor into account. Pancreatitis, as we have already discussed, that it causes, or it stimulates the pancreas in order to increase the secretion of insulin. So they may cause pancreatitis in the patients who are taking GLP-1 analogs. So the contraindications are, if the patient has impaired renal function, you would not give them these drugs. And if the creatinine clearance is less than 30 ml for either of the formulations, so no dose adjustments is required with the semaglutide. So this is the only drug which can be given in the setting of reduced creatinine clearance. Also, the patient who have a history of severe GIT tract disorder, particularly gastroparesis, or if the patient already has pancreatitis, you would not give them these drugs. The next class is alpha glucosidase inhibitors, and the drug in this class is avacarbose. It's a very interesting drug, and the mechanism of action of avacarbose is that it will slow the absorption of glucose from the intestine, which means that the glucose, it will not be absorbed into the stomach, and this is how it controls the glycemic. So it will slow the absorption of glucose from the body, from the intestine. So two drugs are available, acarbose and mezritol, and they are both given in the dosage of 25 milligrams 3 times daily. We would give them with each meal, and as they are going to absorb the glucose, and they will causes the excretion of the glucose from the body, and it would not get absorbed into the intestine. They may cause the GI effects, which includes flatulence, diarrhea, and abdominal pain. Also, there are reports of increased LFTs, increased liver function test, which means that it has a hepatotoxic effect. So if the patient already has any hepatic impairment, you would not give them a carbose. And apart from the increased LFTs, they also have GIT tract adverse effects, which are flatulence, diarrhea, and abdominal pain. The next class is bile acid sequestrants. These are the drugs that are primarily used for the cholesterol management. So its mechanism to reduce serum glucose is not very clearly understood. The drug in the in this class is called as colesevelam. Now, this drug, but it is thought that this is a drug that acts as an antagonist at the farnesoid X receptors. So what happens actually that when it binds or when it antagonizes this receptor, it subsequently reduces hepatic gluconeogenesis. This means that there is sorry. So there will be a decreased production of glucose, and this is how they have their anti-diabetic effect. It is the only studied and approved drug in this class, and the dose is that 625 mg once daily. You would give them 6 tablets of 625 mg once daily. And if the patients who are taking bile acid sequestrants, the constipation, dyspepsia, nausea, and myalgia is very common. So these are the common side effects in this context. Let's move towards the bromocriptine. Bromocriptine is the mechanism of bromocriptine is also again not clearly understood in the hypoglycemic in the context of hypoglycemia, but it is a dopamine agonist. We know that it's a dopamine agonist, and it is thought to reset the circadian rhythm, which can reduce the caloric intake and the storage. So this is a possible mechanism by which it has its anti-diabetic effect. So it resets the circadian rhythm. And this is how it has its anti diabetic effect. So the dosing of bromocriptine is that it is given in the dose of zero point 0.8 milligrams once daily on waking, and it must be taken with food, and the maximal dosage it can be increased up to 4.8 mg, and we have to titrate the doses weekly by 0 0.8 mg per day interval as tolerated and according to the response. So the adverse effects of bromocriptine are usually nausea. Nausea is very common with the use of bromocriptine. It can also cause somnolence, which means that because it's a dopamine agonist, it can cause somnolence. It can cause fatigue, and along with all these, they can cause dizziness, vomiting, headache, orthostatic hypertension, and syncope. So these are the adverse effects of the bromocriptine, and if the patient has any history of psychosis or any psychotic disorder, you would not give them bromocriptine. So the last drug, which is the first line drug, and I've saved it for the last because it's the best drug, and this is the drug that is used as a first line drug in the treatment of diabetes mellitus type 2. What it has a number of actions, and we can see that metformin has a number of actions. In the liver, it is causing an increase in the lipogenesis. It is also increasing the insulin sensitivity. and it also has some other actions as well. But the major actions by which it has its anti-diabetic effect is that it reduces the hepatic gluconeogenesis. It also favorably, so these are the two factors, two major effects, that it increases the hepatic gluconeogenesis, and it also increases the insulin sensitivity, which means that in the muscles and in the all parts of the body it will increase the sensitivity of the insulin, and this is how it causes its effect. So the dose of metformin is that it is usually given at the dose of 500 mg once or twice daily, and maximal dose of it is 2.5 gram, that we can increase the dose up to 2.5 gram, and it can be increased at weekly intervals or as necessary as tolerated, and small initial dosages and then slow titration is usually the best way to adjust the metformin. Now it also has some adverse effects, and the most common adverse effects of metformins are usually GI disturbances, which means that it can cause nausea, vomiting, diarrhea, or any sort of epigastric pain. A less common effect of metformin is that it causes an increase in the concentrations of vitamin B12 levels. So sometimes vitamin B12 supplementation is necessary when we are giving the patient vitamin B of I'm sorry, when we are giving the patients metformin, because patients they may become symptomatic of vitamin B12 deficiency. So we supplement them with vitamin B12. They are also metformin is also very notorious for causing lactic acidosis, and this is because it does not because of the gluco it does not it prevents the glycogenolysis, which means that there will be an increased concentration of lactic acid in the body. And the symptoms of lactic acidosis are usually nausea, vomiting, increased respiratory rate, increased abdominal pain, and increased heart rate. So if the patient is having any of these symptoms, we can say that this is due to the lactic acidosis, which is caused by the metformin. So this was all about the anti-diabetic drugs.